good evening, everybody. I'm Selwan Barbada, and on behalf of the ASMBS Communications Committee, welcome to the top three papers of the top papers 1 and 2 section from the ASMBS meeting in 2025. We are excited to review the great work that was presented, and just in time for everyone to get excited about the ASMBS weekend on November 14th in Louisville, Kentucky. It is my pleasure to introduce our three authors and panel discussants as well. We have Dr. Papasavas, with a bariatric surgeon and professor of surgery at the Frank H. Netter School of Medicine and director of the surgical research at Hartford Hospital. Dr. Papasavas will be presenting the value of patient selection and same-day discharge implementation insights from the MB-SAQIP database. We also have Dr. Avery Brown, who's a rising star, fourth-year general surgery resident at NYU Langone Health. And he'll also be applying this academic year for MAS fellowship. Dr. Brown will be presenting the comparative effectiveness of semaglutide and tirzepatide versus bariatric surgery. And then our third presenter is going to be Dr. Fang. She is an associate professor at Cleveland Clinic, practicing bariatric surgery and foregut surgery as well. She's an assistant program director for the simulation for general surgery residency, as well as an assistant program director for the bariatric surgery fellowship. On our panel discussion, we also have Dr. Abdelrahman Namiri, who's the director of the bariatric and metabolic surgery at Harvard Medical School and Brigham's and Women's Health Hospital. He is also the co-chair of the Communications Committee. Thank you all for using your very busy time here to present your work. Dr. Papasavas, I'll leave it to you.
Thank you. I would like to thank the ASMBS Program Committee for selecting our abstract as one of the top three abstracts of ASMBS 2025. These are our disclosures. Same-day discharge is after surgery is defined as the discharge of the patient on the same day without overnight stay. And this really started with the development and implementation of the ERAS protocols. And it was really the COVID-19 pandemic that accelerated the adoption because of the need to reduce the inpatient burden. There's increasing interest in adopting same-day discharge in high-volume centers with established protocols. However, same-day discharge practice remains inconsistent across institutions. As you can see here, there's a plethora of publications in sleeve gastrectomy patients and same-day discharge that show mixed results and variation in comparison groups. Some studies compare same-day with post-op day 1. Some studies compare same-day with a variety of post-operative periods, all the way to 30 days. While some report higher complications or readmission rates with same-day discharge, others find no significant differences. Overall, mortality differences are generally minimal, with most studies showing no difference after matching. These studies highlight the importance of careful patient selection for successful implementation of same-day discharge in metabolic and bariatric surgery. However, there is a gap because it's unclear how often patients at increased risk are selected for same-day discharge after sleeve gastrectomy. No study has evaluated the association between preoperative risk profiles and postoperative outcomes following same-day discharge in sleeve gastrectomy patients. Our research aim was to compare 30-day postoperative outcomes between same-day and next-day discharge patients undergoing sleeve gastrectomy, stratified by high-risk and low-risk groups. We used MBS-SAQIP 2020 to 2023 patient use file, and we collected all recorded complications. These are our study groups as I described. We included all primary sleeve gastrectomy patients with a BMI over 30. We excluded patients who had revision or conversion procedures, in-hospital deaths, open approaches, and major concomitant procedures. So we included patients who had a hiatal hernia or an endoscopy or a liver biopsy or a gallbladder, but we exclude all other major concomitant procedures. Our main outcomes were the comprehensive complication index, the rate of serious adverse events, and mortality rates. We used multiple logistic regression models for outcome assessment. We chose post-op day 1. This was the median time of discharge in the entire cohort. Plus, it does not make sense to compare same-day discharge with patients who were discharged on 3 or 4 days after surgery. There was a reason why they stayed in the hospital 3 or 4 days. So we chose same day versus next day. We used criteria established in the literature to classify patients as low risk and high risk. Patients older than 65 with a BMI higher than 50, ASA class 4 or greater, or having any of these listed comorbid conditions were classified as high risk. You are all aware of the Clevien-Dido classification of complications, which tends to overlook low-grade complications because it relies on the highest grade complication per patient. Therefore, we use a comprehensive complication index, which is derived from the Clevien-Dido classification, but includes all complications a patient experiences and gives you a score from 0, means no complication, to 100, which equals to death. Every Clevien-Dido grade correlates with a CCI value. I'm going to walk you through an example. Let's say a patient had sleeve gastrectomy, post-operatively developed a hernia that required bowel resection and a reoperation. So that was a 3B Clevien-Dido. That's a CCI value that you can see here. Let's say the patient after surgery had an unplanned intubation. That's a 4A complication, and a UTI treated with medication. If you add up all the values of these 3 complications, you have the total score, and you use a formula to calculate the CCI. In this patient, the CCI was 58.1. A serious adverse event is defined as a CCI greater or equal to 26.2, which correlates with the Clevien-Dido grade 3A. You can be assigned as having a serious adverse event if you have one grade 3A complication or a combination of lower grade complications. So you see how this model captures more than just the highest grade of adverse events. After applying the inclusion criteria, we ended up with 322,000 patients who had sleeve gastrectomy. 12.5% were discharged on the same day. It was very interesting to see that 50% of patients, 49.6%, had at least one criterion to be assigned in the high-risk category. If you compare same day versus next day discharge, there are no major differences, although the p-values are significant. That's because we have large numbers, but pretty much the same age and BMI. The same day discharge patients had lower rates of comorbid conditions. What is of interest to me is that 667 patients were classified as ASA class 4 or greater, and yet they were discharged on the same day. There is no surprise that if you compare low risk and high risk, the high risk patients had higher rates of serious adverse events and mortality. So it's more interesting to look within each risk group, same day versus next day. And the question is, does day of discharge correlate with odds of serious adverse event in high-risk patients? And it does. When you look at the high-risk group, the patients who were discharged on the same day had 26% higher odds of developing a serious adverse event compared to the patients who were discharged on the next day. There was no significant difference in mortality or differences in SAE and mortality within the low-risk groups. Another interesting aspect is to look at the number of risk factors patients had. 70% had a single risk factor, 25.7% though had 2 risk factors. These are the same day discharge patients, and 7.4% had 3+ risk factors. As the number of risk factor increases, the likelihood of a serious adverse event also rises. As you can see here, patients who had 3+ risk factors had 2.1 higher odds of developing a serious adverse event. This is the first study to assess 30-day outcomes of same-day discharge sleeve gastrectomy patients stratified as low and high risk using MBS script data. The key findings: half of the patients who were discharged on the same day were considered high risk based on the criteria that we used. 32% had multiple preoperative risk factors, not just one. 667 patients had ASA class 4 or 5 and were discharged on the same day. High-risk same-day discharge patients had significantly higher odds of serious adverse events versus the next-day discharge. And among those with multiple risk factors were more likely to experience serious adverse events. The observed outcome suggests that same-day discharge practices for sleeve gastrectomy may reflect suboptimal patient selection. And this is in keeping with some of the published studies that also showed dismal results with same-day discharge when compared with next day. We talked about the strengths of our study. There are several limitations. One of them has to do with the ASMBS script data lacking frailty status, patient preferences, socioeconomic factors influencing discharge decisions. We did not evaluate the independent or synergistic effects of risk factors on outcomes, and cases performed in ambulatory surgery centers are not always captured in this dataset. Future directions to develop weighted risk scoring systems incorporating interactive effects of preoperative conditions. Careful patient selection is critical to the safe implementation of same-day discharge in metabolic and bariatric surgery. Patient risk factors should be thoughtfully evaluated as increasing risk burden may compromise postoperative safety. Reimbursement policies could benefit from a risk-stratified approach rather than universal same-day discharge policies. I would like to thank our entire research team, especially Sarah Saidi Shari, who led this project. Thank you.
Thank you very much. That was a wonderful topic, and I think it's a very vibrant topic now. I think a lot of institutions are getting pulled by insurance, by the hospital system, by patients' preferences to try to minimize the hospital stay. This is a very interesting study. I think, especially the way that the patient selection using a CCI for risk stratification is very different. In your practice, right now, for instance, we at our institution we do some selected same day surgery for sleeves and bypasses, and we choose a specific criteria. Have you, based on the study that you've published here, used CCI to create a preoperative criteria for inclusion for same-day surgery patients?
Yes, in our healthcare system, we do not do same-day discharge because we don't have the facility to bring back the patients the following day for rehydration. So therefore we keep them overnight. But if we were to implement one, I would be very conservative starting a program like this. Bariatric surgery has become accepted by the public because of its safety profile. And as a community of bariatric surgeons who worked really, really hard to decrease the risk of adverse events. So yes, it can be done safely in the outpatient setting, but we have to be very careful in selecting the patients.
Yeah, Pavlos, excellent study and very nicely presented as usual. So I have a comment and two questions. So we have a same-day discharge at our hospital, but it is kind of home hospital set up with bells and whistles. So the patient goes with an IV, they get at home someone to check on them. We check H&H the night of surgery. They get checked the next day. In the database, I'm sure there was no visibility in looking at that. But my question is about the methodology of looking at the CCI. So Selwan and I several years ago looked at ambulatory bariatric surgery, and when we excluded all mortalities that happen at post-op day 0 or included them, we got two different results. Mm-hmm. So when you looked at the serious adverse events, did you have a way by which to be able to actually exclude events that happened on the first day of surgery? Because those, you cannot put them in each group. So that's my first question. And my second has to be particularly about VTE. So like two of the risk factors that makes patient high risk is age over 65, BMI over 50. two things that makes you at a higher risk of VTE. Were VTEs one of the driving factors of these serious adverse events?
So, first of all, good points. As expected, we excluded all mortalities that happened on post-op day 0 and 1. But we do not exclude any serious adverse events that happen besides mortalities. So that's to answer your first question. Now, what drives the serious adverse events, whether it's VTEs or other adverse events? The way the study was designed, we did not look at individual studies. It's something that we can go back and look at, what drove the CCI. And this was an approach to look at the entire burden of morbidity that the patient suffers, not just the most serious one, right? Because there are multiple studies that look at Clevin-Dido, or they look, let's say, at rates of leaks or risks of VTEs, and compare same day versus non same day discharge. So it's the first time that we looked at the CCI, so a different way of looking at the complication rate. But we could go back and look specifically at VTE.
And so on, if you allow me just one quick question. I mean, I do robotic surgery, I have nothing against it, but I noticed that the patients who had same day discharge only had 15% robotic compared to double, close to 30% in the next day discharge. Do you think that has played any role, positive or negative?
We controlled for it in the regression analysis, in the regression model, so that what we showed as same day discharge being an independent factor in robotic surgery was in that model.
I think to your point, Dr. Naimiri, your point is well taken, and those risk factors, definitely when you think of those, we're always thinking of VTE risk anyway. It would be interesting to go back and see, in terms of all complications, what is the complication profile of these patients who suffered something, who were discharged same day versus just a normal length of stay. But I would say that most VTE events are happening after discharge, even from not same day surgery anyway. So, but it would be interesting if something was caught, or somebody, let's say, became tachycardic and they stayed longer because they got more monitoring, versus people who went home same day and therefore might have not been picked up for XYZ complication.
Yeah, and I tell you why I said VTE. So in our like home hospital model, the patients get a second dose of Lovenox at home and a third dose at home the next day. And most patients with same day discharge, if they're 65 and have a BMI of 51, are going to be discharged with no VTE prophylaxis, most likely.
Yeah, I think we also do, as Abdel knows, a hospital at home program, and that was going to lead to questions.
I think you're breaking up a little
For
bit,
you
Salwan.
as well as preoperative. Oh, sorry. Can you hear me now?
Yeah.
A lot of these studies look at preoperative assessment and criteria for same day discharge, but I do think there is an importance. And would you feel that there is a difference in how the patients are treated postoperatively when they're discharged on day 1 versus day 0?
So I personally do not have experience with same-day discharge, but I think there's a lot of variation in how patients are managed, right? There are programs like Dr. Nimeri's program, where they have like eyes on the patient. Really, they go home with an IV, they check blood work, they have somebody check on them. And there are other programs that will ask patients to come back the next day, check the vital signs, maybe give them some fluids if they're dehydrated. I keep a close eye that way. But so there's a lot of variation and not like an established accepted protocol.
All right. Well, I think thank you very much, and I think we can move on to our next presenter. This is Dr. Fang, and you can have the floor.
Thank you so much for the opportunity to discuss our project with the community at large. I'll be presenting the work of our research group on marginal ulceration. after conversion of sleeve gastrectomy to Roux-en-Y gastric bypass. Dr. Manning has the following disclosures, and there are no other relevant disclosures. Metabolic surgery, as we know, is the most effective intervention for sustained weight loss, as well as amelioration of weight-related comorbidities. The most common metabolic surgery performed worldwide, as well as in the US, is sleeve gastrectomy, accounting for approximately 60% of all metabolic surgeries performed currently. The sleeve gastrectomy is a great operation for weight loss, and it has a very favorable safety profile. However, we know to look out for acid reflux or gastroesophageal reflux disease, GERD, as it may manifest de novo after a sleeve, or there can be worsening of pre-existing GERD. Typically, this is managed with medical therapy with PPIs. Sometimes we consider the surgery where we convert a sleeve gastrectomy to a Roux-en-Y gastric bypass. Sometimes this can be done for refractory cases of GERD, cases where a patient is maximally medically managed but still having symptoms, or it can be done in the cases of inadequate weight loss and or weight regain. However, there are risks associated with this procedure, including marginal ulceration at the gastrojejunal anastomosis that's created. The marginal ulceration rate in the literature has been reported to range anywhere from 5 to 30%. And so in this study, we aim to examine the incidence of marginal ulceration in these conversion operations where we are transferring the sleeve to a Roux-en-Y gastric bypass and comparing those to a primary gastric bypass cohort. We also wanted to evaluate how the indication for conversion would impact ulcer rates. So this was a retrospective cohort study using our electronic healthcare record system. We compared those two aforementioned groups, ranging from surgeries performed at our institution from 2015 all the way up to 2023. Follow-up was collected up through March 2025. We only included those patients who underwent this conversion operation for the indication of weight loss and or GERD. So we excluded people who had this, for example, say for a fistula or a stricture. Marginal ulcer data was collected first from a natural language model and then confirmed via manual chart review directly from EGD documentation. The Kaplan-Meier method was used to estimate cumulative incidence of marginal ulcer development. Patients were censored thusly, and the log rank test was used to determine differences between the two groups. In terms of our study cohort, we had just over 2,000 patients. About 1,900 of them were primary gastric bypass patients. About 202 were conversion to gastric from sleeve to bypass. In terms of mean age, the conversion group tended to be slightly older, and in terms of mean BMI, the conversion group tended to be of slightly lower BMI. The mean follow-up was 3.8 years. This graph represents the main finding of our study. So this is the Kaplan-Meier curve for patients who underwent conversion of sleeve to gastric bypass in the yellow line versus primary gastric bypass in terms of marginal ulcer rates. So we can see that at 1 year out, the cumulative incidence for the primary bypass group was about 8% versus 12% for the conversion group. At 5 years, it was 16% for the primary group and 27% for the conversion group, and then 20% at 8 years versus 35% for the conversion group. And these two curves were statistically significantly different with a log rank p-value of 0.01. Secondarily, we looked at marginal ulcer rates and compared whether there were any differences when we separated them out by indication for the actual conversion. So whether they were undergoing the conversion for GERD versus for weight loss. And as you can see from the curves and the log rank value, there were no significant differences. So the strengths of this study include the fact that we manually chart checked every single marginal ulcer case, and these were all endoscopically confirmed. And also we manually chart checked all the surgical indications by confirming on the operative reports, and then bolstered it with any and all esophageal acid testing. Limitations include the fact that, obviously this was a retrospective study and the data was limited by what was available in our electronic healthcare record system. Although I will say we did include data from Care Everywhere, and that's getting better and better in terms of capturing data from other hospital systems. Surgical techniques were not standardized over these over these 9 years of the study period. There were about 14 surgeons, and all of them performed their gastrojejunal anastomosis differently. And so there wasn't one set technique for this entire cohort. Also, we didn't consider empiric treatment as a marginal ulcer case, so that was not factored into our case count. So, if somebody post bypass is experiencing pain, nausea, vomiting, perhaps regurgitation, burning pain, and they were automatically put on or empirically put on PPIs and QID Carafate without an endoscopy, we didn't actually count that as a marginal ulcer case. So additionally, this is a single center study, so it is in, technically speaking, one geographical area. So in terms of what we found, the conversion of a sleeve to gastric bypass was associated with significantly higher incidence of marginal ulcer formation than primary gastric bypass patients. There could be multiple reasons that can contribute to this finding. So, of course, there are all the usual suspects for an ulcer. So that includes smoking, NSAIDs, and H. pylori. Specific to, when we consider especially a revision or a conversion type surgery, especially when we're doing it in the setting of, or what we think is increased acid, we need to be aware of the size of the gastric pouch and, in terms of, parietal cell volume that the small bowel is being exposed to. This was not, again, standardized and not something that we specifically looked at in this study, but certainly probably something that contributes clinically. Another idea that, we posited was perhaps there's an element of retained antrum syndrome. So this is where, the distal stomach that is bypassed and thus taken out of circuit is no longer exposed to acid. And in the absence of that acid is unable to turn off that feedback loop. And could that be contributing to the higher marginal ulceration rates? Something certainly that, we don't perform routine distal gastrectomies when we do the conversion surgery, but something to certainly think about. And in terms of our secondary aim, we did not find a significant difference between surgical indications, specifically GERD versus weight loss, and ulcer formation in this sleeve to bypass population. So in summary, at 8 years, approximately 20% of patients who undergo primary gastric bypass and 35% of patients who undergo sleeve to bypass conversion may experience marginal ulceration at the gastrojejunal anastomosis. Certainly further research is needed to investigate all the risk factors that could be contributing to these, high percentages. And while sleeve to bypass remains the mainstay for acid reflux, perhaps, other operations should be considered when we are doing it for inadequate weight loss. Thank you.
Thank you. I think this is a very relevant topic. As we see more and more and more conversion, since the sleeve gastrectomy was a very, very popular surgery, in the past decade. It's interesting to note, that even at 8 years, you're still seeing a quite high and increasing rate of marginal ulcerations in patients. Looking at your data, treatment for postoperative reflux, or at least giving postoperative PPIs for patients, Have you changed your practice based on if they are revisional or conversion surgeries versus primary?
We haven't, and so it is routine in all of our practices across all the surgeons that we give at least 6 months of PPI prophylaxis to patients undergoing primary gastric bypasses. In terms of the revisions, technically we don't have a separate policy for that just because there's a lot of more heterogeneity, but I would be shocked if any surgeon was going less than 6 months. Majority of us, I believe, are probably pushing it out to 1 year, but certainly no less than 6 months, which is what we routinely do as a program for our primary gastric bypasses.
Chelsea, very, very nice presentation and very elegant study. Did you look at the patients who presented with a perforation as the first presentation of ulcer disease? And was there a difference between the two groups?
That's a great question. We did not look at that. And so I actually wonder, some of those people are most likely going to be captured. However, we did not capture marginal ulcer cases from operative reports. We did it from EGD reports. And so in order to capture somebody like that, they would have had to have, some EGD somewhere in their history before and after their perforation where they had a marginal ulcer. So that's a great point, is whether those people who present in extremis had a different risk profile than everybody else.
Yes, because some studies indicate that approximately 20% of patients who develop marginal ulcer may present as a perforation. So it could be that the incidence of ulcer disease may be even higher than your numbers if you include patients who presented with perforation as the first presentation.
And I think that is something that concerned us because we already found these numbers to be quite high, alarmingly high. And, another way that we underestimated is, I do know people who would treat, and quite appropriately so, empirically, if a patient were to, have symptoms that clinically align with an ulcer. We don't absolutely scope everybody, although certainly in the presence of persistent symptoms. So I already do think we are, missing some cases, so to speak. And so this is likely an underestimation if I had to guess. So it's, I think, to me, particularly surprising because I already found these rates personally to be very high.
Yeah. I mean, Chelsea, as Pavlos and Selwan said, excellent study. Is what we expect, really, and nice presentation. I have a comment and a couple of questions. So we've looked at, when I was in Charlotte, about 2,600 gastric bypasses. And we found two things that I want to see if you've looked at in your study. First, we found that a circular stapled anastomosis has a marginal ulcer rate of about 9% compared to linear or hand-sewn about 3%. So did you go back and look at just dividing patients based on circular, linear, hand-sewn? Then the second question is, go ahead, you can answer it, and I'll tell you the second question.
No, so quick response. We didn't for this abstract, but we're going back and collecting that data right now. Yeah.
Perfect. The second thing we found is that the ulcers that happened after circular stapled anastomosis happened early, maybe owing to tension. But the ulcers that happened after linear anastomosis happened late. So I think one other thing you should look at is the duration of the ulcer development. Because in our study, we also did the same thing. We cross-referenced EMR with CPT and ICD-9 codes, and we only considered patients who had an endoscopy. The third thing we found is that the threshold of doing an endoscopy was very significant in ulcers. We found that the rate of having an endoscopy was 15% for circular cases and about 8% for linear and hand-sewn. So I think if you go back and look at the rate of endoscopy in the three techniques, you will know who has a lower threshold to doing an endoscopy.
Yeah, really interesting. Do you think it's a matter of tension in the case of circular versus linear, or is it some way that stapler technology is, clamping down on the tissue.
Sure. I mean, I don't know the answer, but at least in our study, all the circular were anti-colic. And if you go back to history, the description of circular staple anastomosis, certainly this is how I was taught in fellowship, was a retrocolic bypass. And the tension between an anticolic and retrocolic is different. You can tell when you're trying to make an anastomosis. And if you think about it in linear and hand sewn, you create a longer layer of a suture line before you start doing the anastomosis. But in a circular stapled anastomosis, you're basically using the stapler itself, regardless of how much tension there is, to be the one creating the anastomosis. So at least in our data, when we looked at it, it appeared that circular stapled anastomosis was very different than linear and hand sewn, both in duration, in the timing of doing an endoscopy, and on the ulcer rate.
Yeah, very interesting. No, we're certainly collecting that data now, so we're hoping to add that to the report, results reporting.
I think to add on to that, Abdel and I also looked at the pouch size, which you had mentioned. And it's interesting. It would be interesting to look at pouch sizes, looking at your conversion surgery versus your primary. So, some people may not resize the pouch of a sleeve in regards to its width. For instance, it may come just right across it, and it'd be interesting to note, the comparison between those as well.
Yeah, and I tell you, it's not very difficult to do it, Chelsea. You can do CT volumetry, and you can go back and actually measure the pouches. And like Selwan did, when we matched patients, we found that the patients who had a marginal ulcer compared to patients who had a endoscopy, a CAT scan, but no ulcer, every 5 cubic centimeter increase of the CT volumetry doubled the rate of marginal ulcer.
I think I remember reading this paper. Yes. Excellent study.
I've learned a lot from Dr. Nimeri's presentation on the pouch size. And along these lines, I wanted to ask you whether you think that hiatal hernias play a role. We published a study a few years ago looking at MBS squib conversion rates, and we found that 30% of conversions from sleeve to gastric bypass had a concomitant hiatal hernia repair, the highest rate of all conversions, which makes me think that patients may have a hiatal hernia, so a larger stomach. Not everybody's going to dig out the hiatal hernia after a sleeve gastrectomy because it's difficult. So you're going to leave a longer pouch, and you just kind of cut across the sleeve and do a gastric bypass, depending on how bad the adhesions are, versus a primary bypass where you may have a small hiatal hernia, you may not. So how much do you think that could play a role? It would be interesting to look at hiatal hernias, hiatal hernia repairs for both groups.
If I'm not mistaken, we actually excluded those people who had in their operative report a separate, CPT code for a hiatal hernia repair from this particular study. But definitely your point is well taken because, I know for my practice, if a patient has GERD and a hiatal hernia, and after a sleeve, then I'm certainly that this is, definitely one of my, top candidates for what to offer the patient. And so the decision of whether or not we, perform a circumferential dissection of the stomach and get the entire stomach down depends on, many factors such as the size of that hernia. Is it just a small sliding hiatal hernia or is it most of their pouch? And also the patient's symptoms, because sometimes they're not necessarily directly symptomatic from that hiatal hernia. So yeah, those points are definitely worth further research.
All right. Well, thank you very much. I think we'll move on to our third paper, Dr. Brown, speaking on comparative effectiveness of semaglutide and tirzepatide versus bariatric surgery.
All right. Thanks so much for having me to present. I'd like to go over our project from ASMBS this year, as already presented, comparative effectiveness of semaglutide and tirzepatide versus bariatric surgery. This research was in part funded by Dr. Chaubra's K grant from the NIH. And as you guys know, there's many options for obesity. Historically, it was limited to things like lifestyle modification, which offered 5 to 8% weight loss. However, it was plagued by things like frequent weight regain. Bariatric surgery, which was a known commodity of 20 to 30% weight loss, however, is invasive and has complications. And anti-obesity medications, which historically offered 5 to 10% weight loss. However, the new GLP-1 medications, namely semaglutide and tirzepatide, have clinical trial results promising 15 to 21% weight loss. And with those results, there's been an exponential increase in the use of these medications since those FDA results. And at the same time, there's been a decreased utilization of bariatric surgery. However, with all this excitement about these medications, there's still significant knowledge gaps regarding them and their outcomes. For instance, there's little evidence regarding how patients do who are eligible for both treatments. And notably, about 40% of the patients who were included in the original GLP-1 trials would not have qualified for bariatric surgery. And similarly, there's little real-world data pertaining to these medications. Most studies or most data that you hear quoted about them pertain to the clinical trial results and don't come from real-world studies of patients taking these medications. As such, the purpose of our study was to assess for patients who are eligible for both bariatric surgery or GLP-1s, assess their total weight loss at 3 years, as well as their safety outcomes at 1 to 3 years post-intervention. To do this, we pulled electronic health records data from the entire NYC health and hospital system, as well as the entire NYU Langone health system, and then we're able to pull the data together. Our inclusion criteria were patients greater than 18 years old with a BMI of at least 35 who were treated with weekly injectable semaglutide or tirzepatide, or treated with a sleeve gastrectomy or a bypass between 2018 to 2024. We excluded patients with a BMI less than 35, as well as those with preoperative GLP-1 use. We also excluded patients with any prior bariatric surgery. We use average treatment effect weighting to weight our outcomes based on baseline demographic and comorbidity data. And we also assessed our cohorts, especially our GLP-1 patients, in an intention to treat versus per protocol analysis. In our intention to treat analysis, we included all patients who were started on GLP-1s, regardless of length of treatment. However, in our per protocol analysis, we only included patients who were treated with GLP-1s for at least 1 continuous year. Overall, we included over 50,000 patients in our study. Among our bariatric surgery patients, 80% of the patients were sleeve gastrectomy patients, and among our GLP-1 patients, around 80% were semaglutide patients. On average, bariatric surgery patients were younger and less likely to have diabetes treated with insulin. However, there were no significant differences in baseline BMI. This is a Sankey plot of a medication used for the first 6 months for patients who were included in our study and were prescribed semaglutide. What you'll see here is that 68% of patients were started on entry-level dosing, semaglutide 0.25 or 0.5. However, by 6 months, only around 12% of patients had been titrated or were being prescribed a higher level dose of semaglutide, with over 70% of patients discontinuing medication use altogether by 6 months. Similar findings were seen with patients started on tirzepatide, with 72% of patients starting on entry-level dosing of 2.5 to 5 milligrams, and only 12% of patients being titrated to a higher level dose or being prescribed a higher level dose by 6 months. And again, 69% of patients had discontinued medication use altogether by 6 months. These are our weighted percent total weight loss outcomes for all patients included in the study. And what you can see here is that bariatric surgery was associated with significantly greater weight loss at all measured post-intervention time points from 6 months to 3 years, with 3-year outcomes of 4% for GLP-1 patients compared to 23.3% for bariatric surgery. Similarly, in our intention to treat analysis, where we only included patients with at least 1 year continuous use of GLP-1 medications, we again saw that bariatric surgery was significantly greater, had significantly greater weight loss at all post-intervention time points. With greater weight loss for the GLP-1 patients, but still significantly less at 3 years, with 5.9% for GLP-1 patients compared to 22.2% for bariatric surgery patients. And then when we analyze our outcomes by intervention subtype, GLP-1 patients still had significantly lower weight loss compared to bariatric surgery. However, tirzepatide patients had significantly greater weight loss compared to semaglutide patients at 2 years, with 8.9% compared to 4.5%. However, we didn't have 3-year data available for tirzepatide patients at that period, given the only recent FDA approval. And then among the bariatric surgery patients, our sleeve gastrectomy patients, sorry about that. Average weight loss was 20.1% compared to 28.1% for gastric bypass patients. And while hemoglobin A1C wasn't our primary outcome of measure, we did find that in our 1-year outcomes for patients treated with GLP-1s compared to bariatric surgery patients had significantly greater weight loss, A1C decrease at 1 year compared to GLP-1 patients. Among our other post-intervention clinical outcomes we assessed, we did find that bariatric surgery was associated with higher 30-day rates of venous thromboembolism, 30-day rates of myocardial infarction, 1-year rates of hernia development, and 1-year rates of new onset depression. However, we've found no significant difference in 30-day rates of stroke, 1-year stroke, 1-year myocardial infarction, and 1-year cholecystitis. Our study was limited as it was a retrospective electronic health records study. Our data was limited to prescription order data only. We didn't have the medication dispense data. We had no data on the reason for GLP-1 initiation or discontinuation. And finally, our database wasn't nationally represented. It was only limited to patients who resided in New York City. In conclusion, we found that bariatric surgery demonstrated superior sustained weight loss compared to patients treated with GLP-1s. And while patients who were on GLP-1s for at least one continuous year did have better weight loss, they're still significantly lower than those treated with bariatric surgery. And finally, our results showed that GLP-1 patients had significantly lower percent total weight loss in our real-world outcomes compared to what's been seen in the clinical trials. Thanks, and I look forward to any questions you may have.
Thanks a lot, Dr. Brown. I think this is obviously a hot topic that's been going on for the past year or so. Beautiful work by yourself and your group, and well presented. Your results are very consistent. Tirzepatide, we're seeing has a higher weight loss than semaglutide, and it's not comparing to bariatric surgery. And I think that this is a key paper and a key conclusion. I think people we're hoping that we can kind of move meds away, but they're here. I think they're here to stay. I think everyone agrees with that. And so, based on your studies and what your findings are, being kind of you're soon to be your own faculty surgeon with your own practice, how would you recommend to the audience using this data? How would you tailor a metabolic practice based on these findings?
Yeah, it's a great question. It's something that's discussed at both of our main campuses, both NYU Langone, Manhattan, and Bellevue Bariatrics. They both have taken an approach of embracing the medications. So they have multiple providers who, provide the medications and counsel patients on them. And in fact, a lot more of the patients, a higher proportion of patients coming in for bariatric surgery nowadays have had some interaction with the medication before, having tried them in the past, and either they worked for a little bit or didn't work. But it's more of an embracing of the medications. And if it works for the patients, they can still follow them and see them on a regular basis with providers who provide the medications. But if they don't work, or, the patients would like to see greater results or have different interventions and they don't want to take the pills for a lifetime, then they're already within the practice and it's easier to transition them to surgery or other interventions versus, straight from a different clinic or anything like that. So both practices have taken an approach of integrating more of the medication use.
Yeah, and I think especially as we get more literature out there, and your paper here is a prime example. A clinician like myself, I think it's very important to have metabolic surgeons being the ones that control the narrative to the patients, because we can provide and show these results and give them and inform the patients of all outcomes of medications, surgery, endoscopic, what have you, and let them and yourself come up with a joint decision on their care.
Yeah.
be best for them. And so again, I can't express how great it is to see studies like this one. It was very helpful and a very nice study to see. The only other comment I would make is I noticed the GLP-1s. I know wasn't your primary outcomes that you were looking at, but we know that patients on GLP-1s lose a little bit less weight with if they're and maybe we have to tailor those patients, to choose the right option for them.
Exactly. Yeah, that is something we're doing for our manuscript as well, as we are splitting our results for diabetic versus non-diabetic patients and analyzing weight loss. As we know, for diabetic patients, it is a little bit lower for those with diabetes.
Thanks so
Maybe
much, Avery.
no, please go ahead, Chelsea and Pablo. I'll go after you.
Sure. No, just a quick question. First of all, I really love the plot of, the colorful waves. And it tells a great story of like when the rubber meets the road, what actually is happening over time with these patients and the medications. 4% at 3 years is so much lower than what we would all expect. And, for those medications in terms of weight loss. Do you think that boils down mainly to access to the medication as the issue, or is it tachyphylaxis over time? Is it something else? Is it happening on a pharmacologic level, or do you think it's more so, getting the medication into the patient's hands, or compliance, or side effects? What's your take on that big gap between what you guys saw in terms of weight loss with those medications that many years out versus what's reported during those trials?
That's a great question. One of my favorite parts about this project was because it was a collaboration between the NYU Langone Health System, which is a private hospital system, and the NYCH system, which is a public health hospital system. We were able to look at which patients were able to stay on the medications for longer periods of time compared to those who weren't. All in all, the majority of patients were off the medication within a year, and much more of those patients were off by 2 years. The amount of patients we saw who were on the medication up to 2 years was around 2% of patients who were started overall. So it was a very, very large drop off. And among those patients who were able to stay on the medications for longer periods of time were, on average, more likely to be from the private health system. Patients from the NYC Health and Hospital System or public hospital patients did have a lot more trouble accessing the medications compared to those in the private hospital system. A higher percentage of them were undergoing bariatric surgery compared to the private hospital system.
Got it. Yeah.
So it's kind of a multifactorial. It's access to medications, and as well as what's being offered, what insurance covers, Medicaid, Medicare, or a managed plan or something like that. So a lot of it was coming into play, but overall, most patients were not staying on medications long enough to see sustained results.
Got it. Yeah, we definitely need more studies like this. So thank you for your work.
Yeah, elegant study. Congratulations. Along the same lines, the most fair way to compare surgery and medications is really for patients who take the medication, right? Because if you don't take the medication, you don't have the effect, right? And it's a very, very small percentage of patients who stayed on the medication, right? You said only less than 2% at 2 years. So that, raises a question, do you have enough of a sample to make a comparison? And the other question I have is, how confident are you doing this study with the EMR data that the patients actually were taking the medication? Because oftentimes you go on the EMR and you see the medication listed on the medication list of the patient, and you even go to SureScripts and you see that the medication was dispensed. This does not mean that the patient actually took the medication unless you use claim data. So how confident are you doing these studies that the patients who took the medication for a year actually took the medication for a year?
It is one of the limitations, is that we are kind of limited to just the front end data of patients who were prescribed the medication. So we're not sure, they're 100% of those patients who say they took it for a year were injecting, every week for 52 weeks. But I would say we are able to see other information, like whether their weight loss has changed. So we included everyone who was prescribed at least one dose of medication and compared those to people who were given the medication for at least a year. And we were able to track their weights for that entire 6-year time point. So we still were able to see like whether there was any weight change for those patients compared to those who said they took it for a year, and there wasn't very much difference. But unfortunately, we're still not able to see, the exact number of patients who the actual dispense level data and like verified taking it for a year. But hopefully something we can do in the future. I think one of the issues we had with trying to use the insurance claims level data is that it only includes people who have insurance. And we looked into it. If patients were to change or drop their insurance, they're removed from the database. So for us, that was an important part of the access to medications discussion, where a lot of patients who are in the NYC health and hospital system wouldn't show up in that database because they're on public insurance or something like that. So you're losing a large population of patients who would qualify for bariatric surgery when you only limit your study to the insurance claims databases. So for us, that was part of the argument for using our own internal data, where we're not able to verify the medications as much, but we're having a larger capture of patients who are, suffering from obesity and, would require either one of these medications. But definitely something we considered was trying to go the insurance claims route.
Yeah. So Avery, maybe just a couple of quick questions. Really excellent study and excellent presentation. And I echo what Selwan said about the diabetes, because just diabetes on insulin is 1% versus 28% in the two samples. But my two questions are about number one, the bariatric surgery group had an 18% hernia at 1 year. What was that about? What kind of hernia were those?
Yeah, we didn't have information on the specific type, but it was just it was based on ICD-10 codes. So people who had hernias added to their chart within the year after surgery, it was up to 18%. So we're not sure if that was verified by CT or just like a provider saying they felt a defect or potential bulge post-surgery.
Sure. And the second maybe comment / question is, we looked at a similar database of patients who received semaglutide, and we found that patients who had a gastric bypass lost 13.5% compared to patients who had a sleeve or didn't have bariatric surgery. They lost 9 to 10%. So I think in your data set, if you can, maybe, I know you excluded patients who had surgery. If you go back and look at patients specifically who had sleeve or bypass, you might find some interesting findings.
No, that is a great point. So we had another project at Sages last year as well that looked at patients who underwent sleeve gastrectomy and then were treated either with a bypass after sleeve or with GLP-1s post sleeve. And the GLP-1 patients, had less weight loss compared to those who were treated with a bypass. But we did see similar findings that they had sustained weight loss on the GLP-1s compared to the baseline population here, where you're seeing 4 to 5%. We saw around like 12 to 13% weight loss as well. That was sustained even after they were off the medication. So definitely something we want to look into in the future as well, that patients who've had surgery, from what we're seeing, are doing better with the medications after.
And one other comment, I noticed also that the depression was a little higher with the surgical group. You can go and find regret studies for hernias, for a lot of surgeries that are out there. And it'd be interesting to do the same type of comparison with medication use versus bariatric and metabolic surgery, because I can't imagine it's very pleasant to take a shot, daily or weekly, and also just trying to figure out and hassle with insurances and frequent visits and so on. So, but I did note that there was a higher depression rate with the surgical group.
And I noticed that too. It was one of the things that we were discussing within our group. And I think it is related to the fact that most of these patients who are having surgery are being seen at comprehensive care centers that have mental health specialists, they have nutritionists, they have dietitians and everything. So you're screening your patients better and getting a better capture of patients who do have depression, whereas the medications, for the most part, we saw about 10% of them were being prescribed by people with ABOM certification or at MBSA equipped centers. So 90% of those people are just getting them from their general practitioners who may not have the screening access or the capabilities to really pick up on those patients who are suffering from depression. So it's really one of those things where we're just, I think, testing and picking up patients who are undergoing surgery better than those who are getting the medications. So
a great point.
Yeah.
All right. Well, I think if there are no other questions, on behalf of Dr. Namiri, myself, and the Communications Committee, I want to thank you guys all for the time that you guys spent today. presenting your work, and really, most importantly, contributing to the literature. We know metabolic and bariatric surgery is ever changing, and we all want to continue to provide the best and safest and most efficacious care for our patients, and we can't do that without you guys publishing all of your data. So reviewing these studies really was a nice preamble for exciting things to come at ASMBS weekend. I hope we see you all there in November.
Thanks.
Fantastic. Congratulations.
Thanks so much. Have a good one.
Thank you so much,
Thank you.
everyone. Bye.
Okay. Bye-bye.